Good afternoon to everyone present here with us today. This is Sriyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Rajesh Jindal. Sir is the MBBS MD consultant at the Department of Medical Oncology at Medla Cancer Cure Center, Agarpara. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is stomach cancer and overview. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin with. Over to you, Sir.
So nice of you, Ankita. Thank you very much. And good afternoon, friends. I would take this opportunity also to thank Ankita and the team for providing me this platform. And now, without much ado, let us go over the about an overview on cancer stomach. As you can understand, because of the limited time that we have, I'll be able to give you only an overview. So let's get started. And like every place else and anything else, let us start with the epidemiology. How do the slides change? Okay, fine. Now, cancer of the stomach is the leading cause of death in men in Japan. I would be talking more close to home, but the other high incidence countries are China, Finland, Poland, Peru, and Chile. The age-adjusted rate in these countries is up to 95.5, and the male-female ratio is 2:1. However, fortunately for us, we are a low incidence country. The age-adjusted rate, which means that the number of people per 100,000 people is only about 3 to 13.2 cases. The highest incidence in our country is seen in the southern states and in the Seven Sisters of the Northeast. Mizoram, unfortunately, has the highest incidence, but still it would be roughly half of those incidents which is seen in the above countries. The age-adjusted rate in Mizoram is about 50 in males and about 23 in females. The male to female ratio again works out to roughly 2:1. Here in our situation, the cancer of the stomach, unfortunately, starts at around 40 years of age, where in the above countries, the age is about 50 years according to their epidemiological studies. And for us, it is rice, chilies, alcohol, and smoking. These are all supposed to be the risk factors in our situation. There is a high incidence seen in Helicobacter pylori infection and also with peptic ulcer disease. Does peptic ulcer directly lead to adenosis of the stomach or stomach cancer? Well, from what I know, the jury is still out. So I think we'll wait for more data and studies on this. And the location of the gastric cancers in the whites in Europe and in all the other countries which I have cited is migrating proximally. It's going on to the GE junction, is going on to the cardia region of the stomach, and it is going to the proximal lesser curvature of the stomach. Epidemiology done, let's talk about the symptoms in these patients. Cancer patients, stomach cancer patients will present with anorexia early on. They don't feel like eating, kills the appetite, and hence as a result, they would also be complaining of weight loss. Occasionally, the patient is, especially in women, in my patients I have seen, that is that is also the age in which women would be more body conscious, and they think that they are eating less and they're losing weight, and it is good for them, but not always, and this needs to be explored. Some would complain of an abdominal pain located in the epigastric region or in the left hypochondrium region, usually. It may be associated with nausea, it may be associated with vomiting. There may be a change in the bowel habit. Patients who may complain of constipation, altered stool, altered consistency, altered color of the stool, maybe. Fatigue, yes. If the patient does not eat well, then of course the energy levels are low and the patient feels fatigue. Dysphagia, especially if the tumor is in the proximal part of the stomach, which is the cardia or the adjoining GE junction, then of course he would have problems in swallowing the food and it might lead to dysphagia. Then there may be symptoms of the metastatic sites. If the tumor has spread to the liver, it could be jaundice. In brain, it could be an epileptic fit. In bones, it could be bone pains, and so on and so forth. How does it spread? How does cancer of the stomach spread, or how does any cancer spread for that matter? Well, the most frequent spread of stomach cancer is direct extension. It extends by local extension, by local spread to the esophagus. It may spread into the liver, all the adjoining organs, basically. It might go on to the pancreas, invade the diaphragm, invade the bile ducts, invade the omentum and the duodenum. Regional and distant lymph nodes may also be involved. All the lymph nodes around the stomach, the cardia lymph nodes along the curvatures of the stomach, lymph nodes around the antrum and the pylorus. The distal lymph nodes would be the lymph nodes around the left gastric artery, hepatic artery, and others. Hematogenous spread of stomach cancer may be due to lungs, liver, bone, and brain. Well, most of the stomach cancers are adenocarcinomas. 90% of the stomach carcinomas are adenocarcinomas. There could be differentiation, would be a separate issue. It could be mild, moderate, well differentiated, moderately differentiated, or it may be completely undifferentiated kind of an adenocarcinoma. The others are gastrointestinal stromal tumors called GIST. Otherwise, lymphomas of the stomach are quite frequently seen, and there could be all the kinds of connective tissue tumors also, which may arise in the stomach. The prognostic factors, well, the gross appearance of the tumor. How does the tumor look like? Well, more angry looking tumors, fungating tumors have a bad prognosis, and so do the infiltrating tumors. Diffuse infiltrating tumors are less likely to be cured than the sharply circumscribed ones, because they can be easily removed and we can obtain a safe tumor-free margin around those tumors upon surgery. Tumor grade, as I had already said, it could be well differentiated, it could be moderately differentiated, or it could be poorly differentiated adenocarcinoma, which is also a reflection of the aggressiveness of the disease. Then comes the likelihood of recurrence. Obviously, it will increase if there is an involvement of the lymph nodes, or you have a local direct spread of the disease. If the tumor is spread into the adjacent organs, liver and pancreas and bile ducts, omentum, then you have an increased chance of recurrence of these tumors. Dysphagia at the time of diagnosis is a poor prognostic sign, and for obvious reasons. It is that the GE junction could be involved, and also because it will compromise the general condition of the patient for further treatment and for surgery maybe. Proximal lesions and patients with total gastrectomy patients, they would have a poor prognosis because we removed the entire stomach. Probably the patient was operable, but he had disease which had to be operated, remove the stomach. Proximal lesions have a more tendency to spread locally. And so these tumors have a poorer prognosis compared to the tumors on other sides. Well, diagnostic workup, once we've done the symptomatology, once we've obtained the slides and things, now we have a histopathological diagnosis, which have been obtained either by an upper GI endoscopy and a biopsy done from that. We would recommend the endoscopist to take about 6 to 8 samples, chunks of tumor, because these days we have to do a lot of molecular studies also on the tumor. So an upper GI endoscopy is advised, and at least 6 to 8 samples of the biopsy are advised. And after that, all the routine investigations have to be done: complete blood count, liver function test, renal function test, cardiac, ECG, echo, and viral markers, and so on and so forth. ECG and cardiac monitoring would be important because a lot of drugs that we use subsequently in the systemic treatment, they would have cardiac side effects. So we need to establish the cardiac baseline at the beginning. CT scans of all kinds, chest, abdomen, pelvis, with oral as well as IV contrast. If nothing shows up upon the CT scan except for the local disease, and still if there is a doubt that this patient might have a metastatic lesion lurking somewhere, we would ask for a PET scan also. Endoscopic ultrasound is advocated for early tumors. We'll come to that why. Then comes, we need to do an MSI or an MMR assessment on all the tumors, microsatellite instability or mismatch repair assessment for it is done on the biopsy specimen, and it is advocated for all the patients who have been newly diagnosed with stomach cancer. Now, the earlier slide was the diagnostic workup up to stage 3 disease, but if we're suspecting metastatic disease or if we have proven metastatic disease, then we would need some additional investigations, which is the evaluation of the HER2 status. Because if it is HER2 positive, then we can use trastuzumab as therapy upfront in these patients. The PD-L1 status, programmed death ligand, this is used for evaluating for immunotherapy, and the drugs are nivolumab and pembrolizumab. We need tissue sample for next-gen sequencing, NGS, so that we can do the molecular studies and see if the patient has any actionable mutations. Actionable mutations are those mutations against which we have a specific drug and it is available. Then comes biopsy from the metastatic site if it is indicated. If you have an SOL from the liver, in the liver, or something in the lung, not very sure as to whether it is a metastatic site or it is a primary, then of course, then the biopsy would be indicated again. Then you must also do metastatic site-specific investigations if they're indicated. If it does not show on the PET scan, it might be a CT scan of the brain, MRI of the brain. It could be a bone scan if you're suspecting any lesion in the bone. Then comes, how do you do it? Well, HER2 is evaluated either by immunohistochemistry or by FISH. Immunohistochemistry might throw up HER2 as 1+, 2+, or maybe 3+. So 1+ is negative, 3+ is positive, and if the ISC shows up as 2+, then it needs to be verified by FISH. Next-gen sequencing is the molecular studies. It is done to assess any kind of mutation, deletion, amplification of the gene, to assess the tumor mutation burden, MSI, and PD-L1. So with all this information, once we are armed, then we can go in for the treatment part. Cancer of the stomach, unfortunately, is also associated with a large number of genetic conditions. And one of the most frequently seen is Lynch syndrome, which confers a lifetime risk of up to 13% lifetime risk of CA stomach. Although in Lynch syndrome, the more common malignancy is CA of the colon. In Lynch syndrome, we also see CA of the endometrium, CA of the urinary tract, and other cancers also. The Peutz-Jeghers syndrome has the highest risk of CA stomach. It carries with it about 29% lifetime risk of stomach cancer, including other cancers. Then comes the juvenile polyposis syndrome, again a very high risk, 21% lifetime risk of cancer of the stomach. FAP, familial adenomatous polyposis, low risk, 1 to 2% risk, and also of other cancer. And if we are suspecting that this might be a genetic syndrome, then these patients are routinely screened if they have a family history or other risk factors, which may suggest that he might have a Lynch syndrome or a Peutz-Jeghers or other syndromes. Well, there are other conditions also which have an increased risk of developing gastric cancer. However, there is insufficient evidence as to whether they should be screened regularly. And some of them are Bloom syndrome, xeroderma pigmentosa, ataxia telangiectasia, and so on and so forth, going from up to Cowden syndrome and Li-Fraumeni syndrome. Genetic testing. Now, whom should you take up for genetic testing? Well, there are a lot of criteria, and I can only mention them. Elaboration will take a lot more time. Age. So, at what age has a cancer been diagnosed in this patient? 40, less than 40, very suspicious, very doubtful. Or if you have, and then also inquire into the number of first or second degree relatives affected. Number affected, whether it is 1 or 2 or 3, first degree mein kitna hai, second degree mein kitna hai, and at what age were they affected? That also becomes important. All this thing goes into your index of suspicion. And, the more things you have positive, the higher is the index of suspicion, obviously. Is there a history of breast cancer in the same gentleman, in the same lady, or in the family? A pronounced history. Are there other cancers in the family? Colon cancer. We are looking into Lynch syndrome, maybe. Endometrial cancer, Lynch syndrome. Urinary tract, associated with Lynch syndrome again. So are there any associated cancers in the family? First degree relatives, kitne hain unme? Second degree relatives, how many of them are affected? And at what age did they were they actually diagnosed with this, with the cancer? Does the patient have a history of juvenile polyps? And we saw that juvenile polyposis has a high incidence of cancer of the stomach. Gastrointestinal polyposis. Again, this condition also has a high incidence of CA stomach. So if the patient has a history of removal of these polyps at any point of time, at any age, he should be advised genetic testing. Now, is there a diagnosed mutation in a cancer gene in the family? Cancer genes would be CDH1, APC, STK11. And what is more interesting and important are the genes of the Lynch syndrome, which are MLH1, MSH2, MSH6, and the EpCAM gene. So if the patient has any or all of these criteria, And if the index of suspicion is very high, we would ask for the genetic testing of the patient as well. Staging. Now, this is done according to the TNM staging, and T stands for tumor, N stands for node, M stands for the metastatic sites. Tumor staging is TIS, which is carcinoma in situ, T1 to T4. T1 is split into A and B, T4 is split into A and B, and it depends upon the depth of infiltration of the tumor. T1 is localized only to the submucosa and the lamina propria. T2 is the involvement of the muscular layer. T3 is involvement up to the subserosa, and T4, when the tumor goes beyond the subserosa, T4B is involvement of the adjacent organs also by direct spread. Nodal status, it is N0, N1, N2, N3. N0 is there is no involvement of a lymph node. N1 is when you have up to 2 lymph nodes involved. N2 is lymph nodes involved are 3 to 6. And N3 is more than 7 lymph nodes involved. Now, here comes a question. If you are staging, staging a patient, what should be the number of lymph nodes which the pathologist should be able to identify on the specimen? Well, the recommended number of lymph nodes is 16, but in general practice, what they do, they report on the available number of lymph nodes, and if all of them are negative, then it may be reported as N0. It could be less than 16 nodes. M sites, M staging is M0, M1. M0 is no metastasis. M1 is distant spread of the disease. Well, now we come to the role of endoscopy. So from here, the treatment starts, and we would start with the role of endoscopy. Now, endoscopy is used for diagnosis to evaluate the symptoms. If a patient has dysphagia, if a patient has anorexia, if the patient complains of consistent abdominal pain, if there is an incidence of hematemesis, or if he's got black colored stools, then, we would do a upper GI scopy and see as to what is happening over there. Obtain a biopsy, as we've seen earlier. But then what the Japanese also say, the Japanese stomach cancer guidelines, I'm sorry for this misplaced small s over there, it says that lesions which are less than 2 centimeters in size, they should be operated. They may be operated depending on the expertise that you have. And the Japanese have a lot of expertise in CA of the stomach. So it should be operated by EMR, which is an endoscopic mucosal resection, or it could be operated by an ESD, which is endoscopic submucosal resection. It is more technically demanding, ESD. But then endoscopy is not so accurate to evaluate the response to chemotherapy or to radiotherapy. So that is one limitation of an endoscopy. Now, tumor ablation for the short-term control of bleeding, placement of stent, or placement of a feeding tube can all be done by endoscopy. It is done by endoscopy. So that is where the role of endoscopy comes in. And so also endoscopy, you can do the endoscopic ultrasound, and it helps to stage the tumor as well. Then comes endoscopy is also used for surveillance and follow-up after completion of the treatment. Let me see. Okay, fine. So a word about endoscopic ultrasound. Endoscopic ultrasound is one very good tool for staging of the stomach cancers. The ultrasound gives a very accurate picture of the depth of the tumor, whether it is located to the submucosa, into the muscularis mucosa, it has gone up to the subserosa, or it is gone beyond the subserosa. All those layers would appear black on an ultrasound. Similarly, now that you are in the esophagus, in the stomach, you can see the regional lymph nodes, the lymph nodes which are immediately surrounding at the cardia, at the antrum, on the greater curvature, lesser curvature, all those lymph nodes you can see, they would appear black. And you can assess the involvement of the omentum, you can assess the involvement of the spleen, and also the regional lymph nodes, okay, can be seen by the endoscopic ultrasound. So endoscopy in CA stomach, endoscopic ultrasound, I'm sorry, in patients of CA stomach is a very useful staging tool. Then comes, after we've done all these things, let us talk about surgery. Now, what are the resectable tumors? Surgery is the localized treatment. Local treatment is surgery, and most of the patients will get operated to whatever extent at some point of time. Now, TIS, as I said, tumor in situ, carcinoma in situ, or T1 tumors, where the tumor is limited only up to the mucosa, which is T1A, they may be candidates for EMR or ESD if they meet the appropriate criteria. So every center would have its criteria, although some would have the guidelines are there, of course. It should be a well-differentiated tumor. There should be no lymphovascular invasion and all. So it can be removed by either by endomyoscopic resection, or it can be reduced by endoscopic submucosal dissection. Tumors, generally T1B to T3, you would do an adequate gastric resection to achieve negative microscopic margins along with lymphadenectomy. And the procedures which are done could be distal gastrectomy, subtotal gastrectomy, total gastrectomy. Let me first say, I'm sorry, I should have said that earlier, that any treatment plan has to be run through a tumor board. All the three specialties, surgical, medical, and radiation, have to sit together along with the allied specialties. It could be a pathologist, it could be radiologist, it could be from the rehab, it could be from other things also, right? So they would arrive at a treatment plan, and then of course you would carry out the treatment plan. So I was on T4B tumor. So T4B tumors, which are invading the surrounding structures, they would require an en bloc resection of the involved structure also. And just a word of caution over here, the splenectomy should only be done if the spleen is involved, or if there is a high tumor load around the spleen, which could be the lymph nodes along the splenic artery. Then comes early or late disease. There is comparable outcome with either laparoscopic surgery or with robotic surgery. So depends on the center, depends on the expertise available, but weight for weight, I would say, laparoscopic or robotic surgery for early disease or for late disease. The outcomes are quite comparable in expert hands and in high volume centers. Now, we talk about the local surgery. Now comes the lymph node dissection. Definition of D1 and D2 lymph nodes. D1 entails gastrectomy and the resection of both the greater and the lesser omenta, which will include all the lymph nodes as well, along the right side and the left side of the cardia, lesser curvature, greater curvature, suprapyloric, along the right gastric artery, and the infrapyloric area. So major surgery, but yes, it is indicated, it is done, and it gives you good results. D2 dissection is a D1. I mean, you remove the stomach, you remove all the above lymph nodes and the lymph nodes along the left gastric artery, the common hepatic artery, celiac artery, and the splenic artery. Now, if you have operated, there would be some situations where the disease is unresectable also. So that could be, it is a loco-regionally advanced disease. The disease is infiltrating at the root of the mesentery, or the para-aortic lymph nodes are highly suspicious on imaging, on a PET scan, or they have been confirmed by biopsy, which may have been obtained by laparotomy also. Invasion or encasement of major vascular structures, except for splenic vessels, distant metastasis would be a contraindication to surgery, of course. Yeah. If there's an involvement of the lungs, involvement of the bones, involvement of the liver, involvement of the brain, then you can't operate on these patients. There is peritoneal seeding, including positive peritoneal cytology. So upon surgery, if you see that, if you've obtained a sample from the abdomen, the patient presented with ascites, and the ascitic fluid shows that it is positive for cytology, then of course it becomes an inoperable patient. Palliative surgery, let's complete the surgery first. So palliative procedures which can be done are gastric resection. It should be reserved for palliation of symptoms only. It could be obstruction. It could be uncontrollable bleeding in patients with incurable disease. If the patient was curable, if the patient was operable, then of course you would go ahead and do a complete surgical procedure. And in these patients, lymph node dissection is not required, because at the end of the day, it is only palliative surgery. In patients who are fit for surgery and who have a reasonable prognosis, a gastrojejunectomy may be done. It could be done either open, or it could be the laparoscopic way, or endoluminal stenting. So choose wisely whether you want to go into the abdomen and do a gastrojejunectomy procedure, or an endoluminal stenting will help. Now, endoluminal stenting, of course, is helpful in patients. It is preferred in patients who have a gastric outlet obstruction with very minimal metastatic disease in the liver or the other areas affecting the GI tract. If long-term palliation is needed, of course, a surgical bypass may be considered, as we considered in point number 3, maybe a gastrojejunectomy, or we might just do a venting gastrostomy, just do a per abdomen venting gastrostomy and insert a feeding tube maybe from there. Systemic treatment. This is chemotherapy. This is what I do. So systemic regimens recommended for advanced esophageal carcinoma or esophagogastrojunction carcinomas, they can be used interchangeably. And one example is the CAPOX regime, which consists of capecitabine, which is oral, and oxaliplatin, which is an IV drug. Regimens should be chosen in the context of the general condition of the patient, which we call performance status, medical comorbidities, and the toxicity profile. For example, we can't use trastuzumab in a patient who's got a cardiac condition already. But then trastuzumab, if everything else is great, then it should be added to the first line chemotherapy for advanced HER2 overexpression positive adenocarcinoma. That is a dictum, that's a rule of the thumb. And we would generally prefer 2-drug cytotoxic regimes, patients with an advanced disease, because they would have a lower number of toxicities involved with them. The use of 3 drugs cytotoxic, I could use the FLOT regimen. There is docetaxel, there is, capecitabine, and things. So the use of 3 drugs in these regimens should be reserved for patients who are medically fit with excellent PS and easy access to frequent toxicity evaluation. So the patient should be willing, he should be fit, and he should be available for the determination of toxicities. Still on this principles of systemic treatment, drug doses can be modified depending on the circumstances. Alternate combinations and schedules of the cytotoxic are also allowed depending on the availability of agent, practice preferences, and the contraindications on that specific patient. Perioperative systemic therapy is a category 1 recommendation for localized gastric cancer. Start with that, and then you can proceed to surgery or say, whatever. Now, post-operative chemotherapy plus chemoradiation is an alternative option for patients who have received less than a D2 lymph node dissection for whatever reason. Post-operative chemotherapy again is recommended for patients who've had a D2 lymph node dissection done on them. In the adjuvant setting, upon the completion of systemic therapy or chemoradiation, patients should be monitored, yes, of course, for any long-term therapy-related complication. I will give you an example and a setting each. So, drugs which can be, the first way in which we can use systemic treatment is in the peri-operative setting. The most frequently used regime is FLOT, which consists of 5-FU, leucovorin, docetaxel, oxaliplatin, a 3-drug combination. Then it can be used in the pre-operative chemotherapy and radiotherapy. The example is infusional 5-FU, or you can use oral capecitabine. In the neoadjuvant setting or in the perioperative immunotherapy setting, if it is a MSI high tumor, and the drugs used are a combination of nivolumab plus ipilimumab. Post-op CTRT, chemo plus radiation, again, infusional 5-FU plus oral capecitabine maybe. Post-op chemotherapy is again the CAPOX regime, a combination of capecitabine, which is oral, and oxaliplatin, which is IV. Chemotherapy and radiation therapy for unresectable disease, it could be CAPOX, which is the same as the above category. Now, treatment for unresectable or locally advanced or recurrent or metastatic disease, right? So if the patient overexpresses HER2, then you do CAPOX with trastuzumab or one of its analogs subsequently. HER2 negative disease with a PD-L1 with a combined positive score of more than 5, we can use a combination of CAPOX and nivolumab. MSI high or deficient MMR, mismatch repair, independent of the PD-L1 status above, then we can use pembrolizumab. Other drugs and other lines of therapy, there are scores of them. Just to mention some of them: cisplatin, irinotecan, paclitaxel, docetaxel, ramucirumab, dostarlimumab, trastuzumab, deruxtecan, durvalumab, tremelimumab, etc., etc. Now, after we've done the NGS on the tumor specimen, next-gen sequencing, if we find a red gene fusion, we've got selpercatinib, we've got trametinib and dabrafenib for BRAF 600VE mutation. Likewise, any actionable mutation, if we find, we may also have a drug against it. So that is where the role of NGS comes in. Now, we have seen the symptomatology, we've done the diagnosis, we've treated the patient. How do you survey the surveillance after treatment? Well, most of the recurrences, 70 to 80% occur within the first 2 years and 90% within 5 years. Some relapses occur after 5 years also. There is nothing to stop them. But then after 5 years, additional follow-up will depend on the risk factors and the comorbidities. What kind of disease did the person have? Advanced disease, lymph node involvement, local spread, so on and so forth. Only R0 resected tumor carcinoma in situ disease has the prognosis of a non-cancer cohort. The others are not so lucky, and a large majority are the others. Then comes the recommendations of surveillance vary according to the TNM stage, of course, the treatment given, and the local practice. Now, one very important thing which it says is that routine gastric cancer-specific surveillance, that is, radiologic imaging, endoscopic evaluation, and tumor markers are not recommended beyond 5 years. I don't quite agree. I would do this at least once a year with my patients, and I do that. So what do you do in surveillance? Well, history and a physical examination every 3 to 6 months for the first 1 to 2 years, then every 6 to 12 months up to 5 years, complete biochemistry and CBC. Patient who had a partial or a subtotal gastrectomy, esophagogastroduodenoscopy as clinically indicated, CTs of the chest, abdo-pelvis every 6 months for 2 years, and after that annually for 5 years. Then comes you monitor the nutritional deficiency, B12 and iron in surgically resected patients, and we treat them accordingly. Now, what are the issues that we face with these patients? Fatigue. So either how to handle fatigue, either the patient is always resting, he's not working at all. So you ask him to increase the physical activity. You need to build up his stamina. Or the patient is overworking himself. You need to suggest him energy conservation measure. So fatigue, it can be tackled by increased activity, or it can be tackled by lowered activity. Other medical or psychosocial issues, if the patient has hypothyroidism kind of things, you would need to handle those situations, of course. Bone health, monitor and manage the bone density, vitamin D evaluation and replacement. Then comes, then comes palliative issues. What are the palliative issues? Bleeding. After all the treatment is done and things, the patient, if he has a retained stomach, he could not be operated. We just did a bypass, or maybe just did stenting. Bleeding, it could be acute, it could be chronic. Obstruction, inlet obstruction, outlet obstruction. There could be pain due to various reasons. There could be nausea, there could be vomiting, and there could be ascites in these patients, which would need frequent handling, of course. And I think this is my last, no. So after all this, what is the kind of survival that we are looking at? Well, we are more happy talking about 2-year survival because the statistics look good. So in stage 1, we can offer 95.8% survival. In stage 2, 85.9. Stage 3 and 4 are almost similar, 70.5 and 72.2. So this is the 2-year mean survival in these patients. But coming to 5 years, and the statistics drop drastically. Node negative disease, the 5-year survival is anywhere from 45 to 71%. But node positive disease, it can dip as low as 5% 5-year survival, reaching up to maybe 30% 5-year survival. So I think that is all for today. Thank you very much for your patient listening. Thank you very much.
Thank you so much, sir, for your wonderful presentation. So we have some questions from our audience, if you'd like to take that up.
Yes, please.
Thank you, sir. So, sir, the first question from our audience is, are there effective strategies for preventing stomach cancer, particularly in high-risk population?
Yes. Strategies, see, in the first place, as good luck would have it, we don't have such a high incidence of cancer. But if there are families or if there are people who suspect they have reason that they would have an cancer stomach, they should regularly go screening. The screening procedures can be discussed in a separate lecture or issue, I suppose. But then an endoscopy, to start with an endoscopy and a regular history and a physical examination of the patient. Give your doctor your complete family history and your reason to suspect why would you have CA stomach and what makes you a high-risk patient for CA stomach. So you would need to sit down with your doctor, explain it to him, let him assess the risk, and then he would suggest you the appropriate screening procedures. The first of which would be a stool examination and an upper GI scopy.
Thanks, sir. The next question from our audience is, what are the current recommendations for stomach cancer screening and how might they evolve in the future?
Well, how they might evolve in the future is a very difficult thing to say, right? But I see a lot of liquid biopsies coming in, right? People who think that they are at a high risk of stomach cancer, or say any other malignancy for that matter, they might I don't know. I'm just seeing the crystal ball, or trying to see the crystal ball, that it might help. And the current recommendation we just talked. Yeah.
Thank you, sir. The last question from our audience is, are there any promising experimental therapies or targeted agents in the development of stomach cancer treatment?
There are a lot of antibody drug conjugates, okay, which are being developed. One of them I mentioned over here, trastuzumab deruxtecan. And the more exciting development in CA stomach and in all the malignancies in the field of oncology now is coming via NGS, next gen sequencing. We are trying to find actionable mutations. We are trying to locate the culprit. We are trying to locate why did this patient have this tumor, and what are the mutations which are responsible for it? Is it one or is it many? Right. And if there are many, which is the most important, which is a driver mutation, so to say. Okay. And then we would figure out a drug against them. So all these drugs, which I said, selpercatinib and trametinib and these drugs, so they are specific drugs. They are individual therapies, personalized medicine, I would say. So that is where we are heading for. This is one of the most exciting times to be in oncology.
Thank you so much, sir. That's all from our audience. So before concluding today's session, sir, any last remark from you?
Well, I would say, fortunately, we are a low incidence stomach cancer country, right? But then please be on the lookout. Keep your eyes and ears perked up, that any patient who complains of any symptom which has lingered on, and which has lingered on for more than 2 to 3 weeks, right? And if he has come to you for that specific symptom, if he has come to me, if it's come to us with that symptom, let us not just write a pill and send him home. Let us have a very high index of suspicion, because we are cancer in India, from what you and I, we all know, is assuming epidemic proportions. We need to be on our guard. We need to keep our index of suspicion very high. So let us proceed accordingly. Let us have our index of suspicion high, run through the early warning signs of cancer, and then I think we'd be in much better stead and on much firmer ground.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session.
Thank you very